We'll be dealing with psychiatric emergencies, how to undertake psychiatric emergency risk assessment. We have two great scholars that I will introduce you in a few minutes. As I said, I've been directing psychiatric environment in Rome. I'm also the director of Suicide Prevention Center, the only one in a public hospital in Italy, the only one across Italy. And I'm an expert in suicide prevention and assessment, and I'm very interested in learning more about the details of the presentations of these colleagues. Some disclosures and potential conflicts of interest, some relationships with the pharmaceutical industries. And as I said, psychiatric emergencies due to MDD are associated with a significant burden both for the patient and the healthcare system. Emergency departments are at the forefront of suicide risk management and prevention, but this is a challenging environment in which to assess suicide risk. So, as I said in my previous session today, risk assessment is really very, very important. It's very important to document it, to assess that in a very precise and document it. The collection of data regarding the presence of absence of risk and protective factors, as well as warning signs, it is the major goal when meeting these patients. Risk assessment is an integral part of the therapeutic process that creates an opportunity for discussing between the patient, care provider, and support network. When we deal with these patients in the emergency department, we know for sure that it's a challenging environment because it's very busy, and also it is very challenging for us to deal with suicide risk, to manage, and above all, and first of all, to assess that. And having said that, just for learning more about that, it is a great pleasure for me to introduce the two speakers, Professor George Lopez-Castuman, University of Montpellier in France, and Professor Xenia Gonda, Semmelweis University in Budapest, Hungary. And as I said, great pleasure for me, and over to you for the presentation, please. Thank you.
Well, hello, everybody. It's really a pleasure to be here. And thank you for the nice introduction. So these are our conflicts of interest. And now, if it works. No, doesn't seem to work. That's it. Okay, so we've talked a little bit this morning already about what is a psychiatric emergency. You know, this idea of acute change in the way that people, person thinks, acts or feels, and how this can lead to it may require an intervention that is very immediate. But when we think about the emergency situations in depression, there are some specificities, no? And especially, I would like to point out the fact that in the depressive emergencies are very varied. No, we can find any kind of symptoms, and this is not so easy to detect, especially for non-mental health specialists. No? But the important thing that is expected from us as psychiatrists is to detect behavioral risks, and especially suicidal ideation and risk of suicide attempt. Of course, we can find a psychiatric emergency in any environment, in any situation. But most of these emergencies goes through the emergency room. So I will talk a little bit about the emergency room and what is happening with depression over there. Because if we look at the data from the last years, we can see that there is an increase every year. There's a small increase in the rates of depressive persons that goes to the emergency room, and this is not only concerning mental health visits to the emergency room, but generally all persons that are visiting the emergency room for any other reason. Actually, we find a very high percentage of people that is screens positive for a depression, about 25%, and probably the clinical depression is the clinical depression rates are much lower, but some studies signal about 10%, 11%. So it's quite high, and this is a population that is very often undiagnosed. So emergency room is very often the way or the door of access to care for a lot of people. No? So that's particularly important. This is especially those that are undiagnosed, that are not seen by a psychiatrist, but by any other mental health professional, health professionals that are not particularly trained to deal with. And then when asked about, they say, I don't really know how to deal with a psychiatric emergency or a suicidal crisis, or even how to detect a depression. And so people who is going through the emergency room that are depressed are being very often admitted not only to psychiatric but also to other departments. And this particular profile of people with a recurrence of care in emergency, but also in inpatient care, that have chronic diseases, that have low incomes, and that frequently are quite aged. No? So this is a point of entrance and a place where we can do a lot to improve detection of depressed patients. No? And of course, Professor Pompili has just talked a little bit about risk assessment, and this is the importance of. There are several points that indicate the importance of risk assessment in the emergency room, specifically, not only in the patient room or the consultation or ambulatory visit, but specifically in the emergency room, because it is the point of access to care, and because it is the place where the patient gets the first contact with mental health in many cases. So it will determine a lot of what he's going to feel about mental health, or how he's going to feel about the possibility of being treated. No? And it is also the place where we can, with a good assessment, build the foundation of what is going to be the adequate care to prevent any potential life-threatening situation for the patients that are actually at risk. So, of course, to do this risk assessment, we need to work with the patient and the family. There is no good assessment if we cannot get some trust from the patient and the family that will give us a lot of the information. And when we are dealing with this particular risk about suicide, we have to take to take in account a lot of different factors, that include personality factors, that include biological factors, somatic diseases that may increase the risk of suicidal behavior, for example. So I cannot in a few minutes go over the process of assessing suicidal risk, but I think this is the same that we can see here on the screen is quite. It allows us to make ourselves an idea of how this should work. And you see that the core of the assessment is clinical, is how we are able to put together all the pieces of the puzzle, and we build up an opinion of what is going on how we can manage the situation. No? And the pieces of the puzzles include what is the actual situation of the patient, how is he feeling, if he is suicidal, has this idea, what kind of ideas, what is the possibility of acting of this idea, what are also the available resources that he or she has at that moment. So can he mobilize somebody around him, or is he a religious person? This is part of what we can maybe later construct as a safety plan. And we can also think about foreseeable changes. That is something that sometimes we forget about, but it's very important. People that comes in crisis and that can already tell us about what are they being confronted to, and maybe it will change the situation of risk in the future. No? Of course, we have all the risk factors, and Professor Gonda will talk a little bit about that in a few minutes. That we have also to look for, no, all the statistical risk factors that are associated with risk, and will provide us a good idea of the situation. And then finally, we have the use of assessment scales, and this is a particular point that is, for me, a bit controversial, because, of course, scales are very useful and they can help us to improve our assessment of risk. But at the same time, we have to be careful not to rely on them, at least not exclusively. I mean, we can use them, of course. They can improve a lot how we assess things, because they make our assessment much more accurate, much more precise, but we cannot rely on them. And this is the evidence about the capacity of suicide risk prediction with the available scales. Is quite clear at the moment. No, there were a series of papers that appeared in 2017 that compared the different scales and found a common ground for all of them. That is, that they were generally very sensible, but not very sensitive. Sorry. But not very specific. So the positive predictive value of finding a subject with a substantial risk was not very elevated. So we cannot really predict who was going to attempt. No? We cannot at the moment achieve this prediction. Maybe in the future, because there are a lot of developments in the field, and a lot of scales are being specifically developed for specific populations, and that can be really be a revolution. But we will talk about this a bit later. No? So we have to be careful not to be over reliant on some risk factors, on a specific risk factor, but because one single risk factor is not really doesn't tell us much of the real possibilities of acting or making a suicide attempt. So finally, I would like to end up talking a little bit of how we do the assessment also, because this is a very specific part for us as psychiatrists. No? We are very used to do it, and we don't really talk so much about it. No? So we sometimes we mention some questions that we will use. I mean, it becomes such a usual doing for us that sometimes we forget to think about it. No? And I really like when I will quote one psychiatrist in France, that is Professor Terra, that has been teaching on suicide risk assessment for intervention in suicidal crisis for a long time, and he always says that attacking or taking care of a suicidal crisis is like peeling an onion. No, you have to start. You have to take one cape at a time, and the first thing you have to do is when you're in the emergency room, especially, you have to look for the right place to discuss with the patient. You have the right place, the right moment. You have to gain the trust of the patient, and then you can start little by little, after you have gained the trust, to find out what is going on, what is he actually thinking, if he's really having a lot of psychological pain, if he is really thinking or acting of his suicidal ideas, or this is something like fleeting and not so constant. We know that suicidal ideas, the ecological momentary assessment studies in the last year have shown us that suicidal ideas are really dynamic. No, I mean, we can assess them in a moment, and a few hours later they are completely different. The intensity may change a lot. But the moment we examine them in the emergency room, which is the acute moment of the man, it's particularly interesting. And then we have to think especially on how we communicate with the patient at that moment to find out exactly what is going on. So, of course, Professor Pompili mentioned also this idea of looking for the warning signs rather than the risk factors that will prepare us to do a management plan that is really adapted to the patient and that can be followed up in hospital care or in a voluntary care in the future. So to sum up, I have to take home messages from you, and this is first one. Major depression is very frequent in the emergency room, and we are not really taking or detecting a lot of what is really going on with these depressed patients in the emergency room. And then we need to start assessing risk of suicidal ideation or suicide attempt from the very beginning, and try to build up a comprehensive plan from the emergency room to continue care afterwards in other departments. Thank you so much.
So thank you very much, and I'm trying to pick up from here, and I may not have a very easy task, because some of the things I'm going to present to you, some of the things I'm going to discuss with you are going to be a bit controversial. I'm first of all going to speak on actually risk factors and protective factors of suicidal behavior, or imminent suicidal behavior, or long-term suicide risk, and we already heard Professor Lopez-Castro that this factor may or may not be very useful or very reliable. As one of my mentors and one of my favorite bosses, Professor Zoltán Rímel, many of you know him, always said that it's better to prevent suicide than to predict it. Actually, if we know the patient very well and we are treating the patient very well, then we may be able to prevent suicide. On the other hand, it's very difficult, even if we are working closely with the patient, to predict suicidal behavior. We have very few things, very little things to actually rely on. And in spite of their shortcomings, in spite of their low specificity, low sensitivity, or in cases where they are highly sensitive, the low specificity of the suicide risk factors may be a big obstacle, a big setback, but still these are the best evidence-based factors, the evidence-based key points we can actually base our suicide risk assessment on. Also, the assessment of risk factors and protective factors can be useful for us to make suicide risk assessment documentable and also somewhat less subjective, so they can provide good key points around which we can base our evaluation on, our assessment of the actual suicidal patient on. The key issue is to consider these risk factors and also the protective factors in constellation and also in the context of the patient, and look at their mutual relationship, how they contribute to the actual dynamic of suicidal behavior developing in case of a given patient. So these risk factors and these protective factors are not just a simple list you tick off, because you can see that many of these characterize most of our psychiatric patients, most of our major depressive disorder patients. The majority of us never proceed to go on for actually committing or completing suicide. So when we are considering suicide, the risk factors, for example, as I have mentioned, always look at the dynamics between them, look at them in constellations. These risk factors can concern several areas. So the first large group of such risk factors includes the psychiatric background and the psychiatric history. We know that the majority of patients who are actually attempting or committing suicide, over 90% of them are psychiatric patients. The majority of this 90%, 2/3 of them actually come from affective disorder patients. The rest is schizophrenic patients and personality disorder patients. What we also have to look at is comorbidities next to psychiatric diagnosis. Substance use or substance abuse is a high comorbid risk factors, also an associated personality disorders. The personality disorders are frequently not recognized in addition to major depressive disorder, but it's always very important to consider them because they can be associated with such personality characteristics as, for example, cyclothymia, as, for example, increased impulsiveness, which greatly increase the risk of suicidal behavior. So it's always the context of psychiatric disorders and psychiatric comorbidities. We also have to look at the family history of suicidal behavior as an important psychiatry-related risk factor, because family history contributes to increased suicidal risk via two different mechanisms. One is, of course, heritability. Suicide has a very strong genetic background, and also by mother learning patterns from our family members on how to cope inadaptively with a situation we cannot really handle. And of course, one of the most important risk factors for an upcoming suicidal behavior is the presence of a previous suicide attempt. But of course, our aim is to prevent this previous suicide attempt and not to use it as a potential risk factor. Now, in addition to psychiatric-related risk factors, we have the other bunch of important risk factors for estimating the approaching risk of suicide, which is related to personality factors. We have several of them which have been shown in several studies to be associated with suicide risk, especially in case of psychiatric patients. These include poor self-control, these include impulsiveness, also long-term life dissatisfaction, and for example, temperamental and other personality traits such as affective temperaments, mostly cyclothymia, which provides not only rapid mood swings, but also to drive to act upon these mood swings and act upon a depressive state and commit actually suicide. One very important long-term risk factor, which is considered more like a personality trait, is a history of abuse and trauma, especially in the early childhood, because these are those risk factors which are actually acting through neurobiology. So they establish a long-term biological-based suicide risk. And of course, we have the third group, which has to be present for a suicide act, a suicidal attempt, or completed suicide to be precipitated, is the actual stressors. The actual stressors, which in opposition to the distal stressor factors, are more proximal and which act upon this long-term risk of suicide, such as recent losses, recent struggling and difficulties, for example, financial issues and comorbid somatic illnesses, especially chronic somatic illnesses, or a newly onset somatic illness. Now, most of these risk factors are unmodifiable. And on the other hand, we also have to assess when assessing suicide is the protective factors. Now, the good point is that several of the protective factors are modifiable, and they may not be able to modify them on the short term, but if we are managing the patient who has a disorder such as major depressive disorder, which is associated with increased risk of suicide, then we can work on modifying these protective factors in the long term. What do they include? Most importantly, a good therapeutic relationship with the treating physician, and also a good relationship and a close and dynamic relationship and a burdenable relationship with mental health care settings. Also, very important protective factors include social ties and social connectedness, and a good protective and a good supporting the social network, which include having family or children, having a strong connection to the community or a supportive network, and also having strong connectedness with spiritual and religious groups, and having strong beliefs, morals, or ethics related to spiritual or religious issues. We also have personality factors, for example, the adaptive coping skills and adaptive problem-solving skills. Adaptive coping skills can also be developed on the long term. Problem-solving skills can be tackled with, for example, cognitive behavioral therapy techniques also on the short term. And finally, protective factors, which we have to assess, are very important reasons for living, and also a sense of having a sense for life, having self-esteem, and also belonging. Now, when we are assessing suicide risk, we are going to weigh up these risk factors and protective factors one against each other, but we also have to consider that they are more risk factors on the long term. So they may not be so importantly risk factors for the imminent risk of approaching suicidal behavior. What will signal this risk is actual warning signs, which we should also assess in case of the patients, which means the verbalization or the expression of suicidal ideation, the verbalization or the expression of a suicide plan or the evidence of a suicide plan, also seeking access to mean or at least having access to mean to suicide, and the expressed threat for life. Other warning things include such cognitive processes and cognitive contents as hopelessness and the feelings of entrapment, the feelings of being trapped, and also several behavioral changes in constellation of all the above can signal the imminent risk of suicide, such as, for example, increased impulsiveness, risk-taking behavior, anger or restlessness, withdrawing from friends, and also the onset of severe anxiety or agitation. So when we are speaking of assessing these factors, we always have to think of them in constellation. We also have to think of them in relationship, in a dynamic relationship with one another. Because it is true that the patient's actual level of suicidal risk increases with the number of associated risk factors, but it's never just, as I have mentioned, ticking off the list. We have to look at how they influence one another. So one of the goals of risk assessment is going to be that based on these risk factors and protective factors and warning signs is to establish the overall level of suicide risk in case of a patient. And we have a couple of points on how to assess, how to assign a higher level of suicide risk. We have to look at the patient who express high degree of suicide suicidal intent. Those who are able to describe, or those who disclose toward us a more specific suicidal plan or a more detailed suicidal plan, especially if they are describing more irreversible methods or more violent methods or methods which involve more a higher degree of medical injury. Also, it is very important to have for a signal if the patient has a personal history or a family history of suicidal behavior. And we all know that the period after being released from hospital is also very high risk behavior. So we also have to consider this when we are trying to assign a general level of suicide risk to a given patient. Now we have many challenges and many problems. It can be indeed very challenging to balance, to weigh up risk and protective factors to give an approximate view or an accurate view of the suicide risk. And suicide risk categorization can result both false negatives, that is missed fatalities, and false positives. And we all know what is the risk associated with missing a patient with a high suicide risk, which may lead to the actual, not only suicide attempt, but the actual completed suicide. But false positives are equally problematic, because if we give a false positive high suicide risk assignment to the patient, then we are going to cause harm. We are going to be leading to an unnecessary commitment to a psychiatric facility, which is going to be traumatizing the patient, which is going to be stigmatizing the patient, which is going to significantly impair our therapeutic relationship with the patient, and which is going to significantly decrease the chance that the patient is going to openly talk to us about the potential risk factors or his potential suicidal ideation or suicidal attempt. And as I have mentioned, the challenges also involve that these suicidal risk and protective factors are not just a list we can choose from. They are not static, they are dynamically changing over time. I have mentioned that there are several important personality contributors to suicidal risk, such as, for example, impulsiveness, such as, for example, cyclothymia. So anything that directly or acutely happens in the life of a patient with major depressive disorder, for example, can very quickly make him develop a suicidal intent or start working on a suicidal plan. Also, we know that commonly the risk factors of suicidal behaviors have a low specificity, so they are poorly able to distinguish those who will actually attempt suicide. The best documented suicidal risk factors include depression, impulsiveness, and hopelessness. We all know that in themselves, these are not going to be able to hide specific suicidal risk factors because they characterize the majority of our major depressive disorder patients. The other thing which can actually be used to make our suicidal risk estimates more accurate is to use assessment scales. Now, we have also heard from Professor Lopez-Castroman that the actual use of suicide assessment scales to capture suicide risk carries several problems. And yes, we should not overly rely on them. They are useful still for many things. For example, they are useful for documentation purposes. It's very important to document suicide risk because of, first of all, because of the legal consequences. Also because the treatment of suicidal patients is usually a teamwork. If we have an outpatient who we are treating, if there is going to be a severe suicidal ideation developing, then this patient is going to present in an emergency room or an inpatient psychiatric unit. So we may not be the first one who we are going to meet these patients. It's very important for those, all of those who are contributing to the treatment of these patients to be able to have access to documentation, to be able to have access to the documented previous suicide risk. Also, these different suicide assessment tools capture different aspects of suicidal risk. Some of them has a broader scope, some of them have more depth, some of them are more comprehensive, and several of them just focus on one of the aspects, a few of the aspects of suicidal behavior. So besides quantifying suicidal risk, many of these scales can also be used just to focus on certain aspects of suicidal behavior. And if we are treating the patient with a combination of pharmacotherapy and psychotherapy, or at least supportive therapy, then we can actually look at how these, based on how this suicide risk scale assess these suicide-related factors or content, we can also see what we need to focus on. So I have mentioned that these suicide risk scales differ in many aspects. We have one of the best known and most widely used and most reliable instruments, which is the Columbia Suicide Severity Rating Scale. This is a tool which, first of all, needs training and which comes in many versions. For example, the lifetime versions, the recent suicide risk since the last contact. And it is very wide in scope. It assesses all aspects of suicidal behavior, including ideation, including behavior, also including the intensity of the ideation. Whereas the other scales usually focus on just some parts of this and have been developed based on different theoretical aspects. So we have, for example, the Beck scale for suicidal ideation or the Beck hopelessness scale, which focus on cognitive content. For example, attitudes towards suicidal behavior, attitudes toward life, positive outlook on life, hope of life. We have other scales which focus on, for example, the intensity of ideation. It's also very important that during assessing suicide risk with assessment tools, we cannot only use instruments which focus on the actual suicide risk or aspects of suicidal behavior, but for example, we can use the TEMP scale, the temperamental scales, affective temperamental scales, to identify if there are such personality factors, such temperamental factors, for example, such as the cytothymic temperament, which on the long term increase the risk of these patients of actually switching quickly between such states, which involve a low mood state like depression and which involve a high drive state to act upon this very bad mood and commit suicide to end this suffering. And because of the fact that these suicide risk assessment scales in many cases are not very informative, not highly specific, they are rather assigning a number to the patient on suicidal risk, and we should not overall rely on, especially with the current paradigm shift towards precision psychiatry. We have new novel computerized tool in development, which will use different algorithms of collecting different suicide risk factors, and which are with different computerized algorithm, computers-based algorithms are going to collect these risk factors and are going to assign a more reliable calculation-based risk to a given patient. We have listed two here. One is the CAT-SS, the computerized tool for suicide scale, and the OXMIS, which is the Oxford Mental Illness and Suicide Scale. Of course, in the long term, what we are hoping for is that these computerized tools, which use machine learning algorithms, are also going to include biomarkers. For example, we have new novel research showing that cytokines and pro-inflammatory markers in the blood may have quite a good specificity in signaling suicide risk, and we are also going to have imaging markers. So what we hope is that we are going to be able to use computerized assessment tools which are going to be able to predict suicide risk in a more specific and a more sensitive way. One very important aspect of suicide risk assessment is to actually find out that which of those patients who are expressing suicidal ideation will proceed to attempt suicide. As I have mentioned, this is very important because false positive are equally problematic in our psychiatric practice, because they are going to lead to the stigmatization of the patient, unnecessary commitment to psychiatric ward, and also are going to deteriorate the confidentiality between the patient and the doctor, and is going to burden the therapeutic relationship. So it's very important to better understand suicide risk and also to understand how the patients are going to communicate to us regarding their suicidal ideation and regarding their suicidal plans. It is very well known that patients may not always verbalize suicidal ideation. Actually, there has been studies which show that 76%, so more than 2/3 of patients who died by suicide denied having suicidal ideation when asked, and 50% of these patients, half of these patients actually died by suicide within 2 days of denying they have any suicidal intent. And the other side of this is that it's not only patients are not verbalizing their suicidal ideation or their suicidal plans, but of course, we are also missing indirect suicidal communications in our practices if we do not know the patients very well. So it's also very well known that 44%, more than 40% of those patients who commit suicide contact their mental health professional within 1 month prior to the act, giving us the chance to actually understand and trust those meta communications or direct communications which are related to the approaching suicide risk. So when we are we are creating a clinical judgment or working on a clinical judgment if there is actual suicide risk in case of the patient, there are many factors we have to consider. We have to consider them in constellation. We have to focus on the dynamic relationship between these factors, on how they dynamically mutually contribute to the emerging risk of suicide in case of the patient. So we have to focus on the actual level of intent in the patient and the actual level of risk. We should collect and weigh up warning signs and risk factors. We should also incorporate in our assessment or in our clinical judgment the results of scales and the results of other assessment tools. We have to also incorporate and include relevant parts of history, which include psychiatric history related to previous suicide attempt, previous treatments when the relative was successful or failed treatment. And also we have to include as specific information as possible on suicidal thoughts, suicidal ideation, and suicidal plans. And when we collected all these factors, we are going to formulate our clinical judgment and use this information to formulate our treatment plans and also the prevention plans in case of suicidal behaviors. So risk assessment, as we have described, has several challenges, and it's very difficult to practical advice. We would definitely need better tools, and we have hope that with the era of precision psychiatry, we are going to have computer-based algorithms and computerized tools. We need also, based on these tools and independently of tools, better training and education in order to improve risk assessment of suicide in the emergency settings. Several challenges we have, for example, in all settings, all of those contributing to the treatment of suicidal patients, we need to improve the knowledge concerning the history of the patient, involving both medical history and psychiatric history. We have to develop standardized risk assessment procedures across different facilities, so I know what I can expect in the psychiatric department concerning the evaluation of the patient who is presenting in an emergency room. We need to establish the time for in-depth investigation or in-depth evaluation of the patient, for interviewing the patient at several settings. And of course, we need a good therapeutic relationship, and we need to develop means of developing a good therapeutic relationship in different settings who assess suicide or risk in patients. So the practical advice we would like to give is not very simple. We only have a few cues. For example, to develop communication skills and interview skills, once again, for all settings where suicidal risk patients remain present, and also develop our relationship with the patient, develop means of getting into good rapport with the patient, and also to train the contributing mental health professionals on how to not to be afraid to communicate with the patient, how not to be afraid to ask the suicidal patient about risk. We'll also be able to develop better means of collaborating with one another during the risk assessment and also during the subsequent follow-up treatment of the patient, particularly when we are working with or managing a patient who we are unfamiliar with. And it's very important that we should use assessment scales because they provide communication between the different professionals by quantifying suicide risk. So we should have good assessment scales which provide relevant information, and we should use them at different levels of the care. So this is what I would have wanted to present to you, replying to all the very relevant information by Professor Lopez-Castroman. And now we are going to actually try to discuss from both sides the usefulness of these factors, for which I'm going to sit down. So you should.
Thank you very much indeed for this presentation. So.
Thank you.
They were just enriching and important for clinical practice. There are several questions that we'll address. But before that, just try to summarize the pros and cons that you provided in this slide.
So I will start, if I may start, because the first of the contributors to suicide risk assessment was actually to assessing the situation and the context. And we have talked that this may be actually one of the most important aspects, because this, in contrast to just listing a couple of risk factors and protective factors, actually looks at the situation, looks at the situation, its dynamic context, in its temporal context, and also help us to empathize with the patient and get into contact with the patient. So I think this is a very important part of suicide risk assessment. I don't know what you think.
I think, but I have to clarify that we decided to bring this debate somehow, and I have to take position, but it's not that I'm against inquiring about the context. Of course, this is what I just said before on the presentation. Actually, the problem is that all of this, these different levels of the assessment, all of them has also their own limitations and their limits on what to what extent we can rely on them. No? And when we think about the context, this is not always something we can rely on. I mean, normally you can rely on the family, and you should rely on the family, but this is not always the case in some particular dysfunctional families. No? Or sometimes you have patients that arrive in the emergency room and you all have the experience probably of situations where you don't really know what is going on. You have still to have to make a risk assessment, no? Or you have an information that is you don't know how accurate it is. Of course, you have to look for the information, but you cannot base your decision on context alone, and that's the main point of all this discussion. No, when you bring the assessment to your mind, you have to put all together. Context, of course, is a piece of the puzzle. It's important, but alone it doesn't mean much, and it's the same for the other dimensions.
Okay, then let's mix in assessment scales. I know you are going to object to them too, but I think assessment scales are good because they are standardized measures. They take out the subjectivity, they take out the level of personal experience. So assessment scales, even the second-year resident can safely use in the emergency setting when they have little time for the patient and they have to still assessment the risk. So they are fast, they are quantifiable, they are able to focus on different contributing risk factors. So I think they can be used in several settings and they can thus be quite useful. So why not? Tell me.
Okay, you have, why not use but I think that the main point for me is that using excessively long or rigid assessment scale in the emergency context, it may be they damage the clinical relationship. That for me is the main point. It's not so easy to examine suicidal risk and create a trust relationship and at the same time apply on a scale. So that's why from my point of view, at least with the information we have now, the scales should be integrated in the assessment, but not as a different instrument that you apply, but that the points of information that are in the assessment, you do them while you are discussing with the patient. And then afterwards, you can use that information to clinical decision making. No?
Very good. Thank you very much. I will going over the conclusion with the fact that there are some questions, and it's a real pleasure to provide you some insight into the thoughts that you have been dealing with, because there are participants that are asking, is treatment-resistant depression a risk factor for suicide, or is more driven by depression severity?
Well, the treatment-resistant depression is associated with suicide risk. That's clear. But so is the severity of the depression. So I think both are risk factors, and you should take you should consider both if you are examining a patient with the treatment-resistant depression. You should consider also the severity of the episode he's living in, and also past episodes, of course.
Yeah, very briefly, another question from a participant: how strong is the link interconnection between impulsivity and the hopelessness for the suicide risk?
Impulsivity and hopelessness?
The interconnection between impulsivity and hopelessness.
Yeah, hopelessness is the general lack of positive outlooks, the positive perspective, actually the view of the future, if there is any future, that is only going to lead to a suffering. And this, when it's built on impulsiveness, is going to lead to the patient actually to very quickly act upon this. Impulsiveness is, in a sense, acting upon a thought, only looking at how the immediate consequences are going to be useful or are going to alleviate suffering without consideration of the long-term consequences. So hopelessness is essence the lack of long-term perspective, of a long-term positive perspective, and impulsiveness builds upon it, just focusing on what is going to bring an alleviation. So it's once again, we have to view them in constellation. We have to view the dynamic relationship between them, and then it's quite close.
Great, thank you. I need a very straightforward answer for this question. In your opinion, which assessment scale would you use if you were to only select one scale for a general implementation in your clinic?
Is it for you?
If you need to select just one scale for your clinical practice, just one.
I would use the Columbia Suicide Severity Rating Scale because it's really comprehensive.
Yeah. What about yourself?
I would also choose, if I had to choose one, I think the evidence to date is mostly to use this scale. But my hope is that we will actually develop this computerized adaptive test that will allow really to select the questions that are most relevant to the patients. And that's really not so difficult to do. And the studies are very promising because you start with a single question, and depending on the answer, you will adapt the question later. And so you don't have to ask 20, 30 questions. And that's I mean, that's my hope for the future.
It's a way to burden, because suicide scares, if they are lengthy, it can be burdening on the patient. So it's a very, very important.
Thank you very much indeed. And it's been a very great pleasure for me to moderate this session. It's been an enriching opportunity to learn more about the assessment of suicide risk, to deal with the psychiatric emergencies, and just some points, some thoughts about the risk assessment, as we said, is essential for establishing the need for emergency mental health consultation and determining subsequent treatment options. Also, assessment of suicide risk should take various factors into account, including the situation and the patient's history and lifestyle. And last but not least, a combination of clinical judgment and assessment scales appropriate to the individual patient should be used. Again, thank you very much indeed, and please follow the instruction from the breakout sessions. Thank you.
Thank you.